Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me as we share conversations with colleagues, exploring their special interest in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an expert about rhinitis, sinusitis and rhinosinusitis. Before we start, for Australian audiences, listening does give you eligibility for your CPD, so you can log in and add this as an activity, and you may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, rhinitis, sinusitis, and rhinosinusitis are common conditions presenting to primary care. In one study, 1.4 per 100 general practice encounters were for either acute or chronic sinusitis, and over 2 million Australians are estimated to have chronic rhinosinusitis, which in some studies has been shown to have a greater impact on social functioning than chronic heart failure, angina or back pain. Well, to review the anatomy, the paranasal sinuses are paired, and they include the frontal, maxillary, ethmoid and sphenoid air cells. They're lined with a ciliated, pseudostratified columnar epithelium and goblet cells, which provide a mucociliary blanket that traps noxious particles, transporting them from the sinus to the nasopharynx by the action of cilia. Significantly, the maxillary sinus, which is the largest air-filled sinus in the body, has a draining ostium that's only, on average, 2.4 millimeters in diameter, and this is easily subject to blockage during periods of infection or immune-mediated inflammation. One of the targets of medical and surgical treatment in managing sinusitis is to restore and assist mucociliary clearance and sinus drainage, whilst also addressing the pathophysiology of the associated inflammation. So in further discussion, turning our attention firstly to acute rhinosinusitis, the spectrum of acute rhinosinusitis, called ARS, includes the common cold, post-viral ARS, and acute bacterial rhinosinusitis. It's estimated that less than 2% of episodes of viral upper respiratory tract infections are complicated by bacterial transformation, yet there is a tendency for the medical profession to prescribe antibiotics for more than 85% of presentations of sinusitis. ARS presents with symptoms of nasal obstruction, discharge, changes in smell, facial pain or pressure and cough. The facial pain often worsens on bending forward and can radiate to the teeth. Diagnostic criteria include sudden onset of 2 or more symptoms, one of which should be either nasal blockage or congestion obstruction or nasal discharge anteriorly or posteriorly, plus facial pain or pressure and or reduction or loss of smell. Examination of the nose should include a check for the presence of discharge, which could be clear mucus or repellent material, polyposis, swelling and erythema. A clinical assessment is normally sufficient for diagnosis, and plain x-rays yield little information. The use of CT scans really should be reserved for cases where there are complications suspected. And patients with acute viral rhinosinusitis, ARS, should be treated for 7 to 24 days with supportive therapies including regular analgesia, nasal saline irrigations and nasal decongestants. A Cochrane review found a modest benefit with intranasal steroids. Red flag symptoms include bleeding, cachosmia, which is a perceived malodorous smell, signs of meningitis, altered neurology, frontal swelling, any orbital involvement including diplopia, decreased visual acuity, painful ophthalmoplegia, periorbital edema, and erythema and globe displacement. We're turning our attention to chronic rhinosinusitis, CRS. This exists in 2 forms which are differentiated by the presence or absence of nasal polyposis. CRS is defined by the persistence for more than 12 weeks of symptoms including nasal congestion, nasal discharge, facial pain or pressure, and reduction of smell. And as for ARS, viruses and bacteria are the most common etiologies. Streptococcus, pneumococcus, Haemophilus, and Moraxella are the most common bacterial causes. However, allergy and structural factors like nasal polyps and deviated nasal septum, as well as ciliary dysfunction and immunodeficiencies and fungal infections should all be considered. And treatment of CRS should commence with a trial of topical steroids and twice daily nasal irrigation for at least 8 weeks. If nasal polyposis is evident on examination, a pulse of oral steroids should be considered. A Cochrane review found that a short course of prednisolone commencing at 25 milligrams produces a significant reduction in polyp size and subsequent subjective improvement in sinonasal symptoms. The inclusion of a macrolide for at least 8 weeks has also been shown to enhance mucociliary function, reduce inflammatory cytokines, and may also reduce polyp size. So when medical therapy has failed, consideration should be given to surgical management. This is referred to as functional endoscopic sinus surgery, or FES, and involves endoscopic removal of polyposis when present and improving ventilation of sinus cells. Major complications are rare, but do include damage to the extraocular muscles, loss of vision, cerebrospinal fluid leak and meningitis. Well, it's important for patients to be aware that CRS is an inflammatory condition of the mucosa and that as such, sinus surgery is not a cure for the condition. Rather, it's an attempt to allow better symptom control. Ongoing use of topical steroids and nasal rinses are often required post-operatively to control mucosal inflammation. This is especially true for those patients with polyposis, with up to 60% requiring a further polypectomy within 5 years. And patients with CRS also often have asthma. Up to 50% of patients have coexisting disease. And SAMHSA's triad is defined by the presence of non-steroidal anti-inflammatory drug sensitivity, asthma, and chronic rhinosinusitis with nasal polyps. Thirdly, allergic rhinitis, commonly known as hay fever, affects around 18% of people. Despite its common name, allergic rhinitis is not caused by hay and does not result in fever. The condition typically presents with recurrent episodes of sneezing, pruritus, rhinorrhea, nasal congestion, and lacrimation. And these symptoms occur after exposure to an allergen which stimulates IgE-mediated mast cell degranulation. Allergens can often be identified by history taking. However, in the absence of clear precipitants, radioallergosorbent testing, RAST, serology may be indicated. Treatment consists of patient education regarding allergen avoidance strategies and oral antihistamines. Second-generation non-sedating oral H1 antihistamines have a quick onset of action with a small side effect profile and can be safely used in children. Referral to an immunologist for desensitization, referred to as allergen immunotherapy or AIT, may be considered in the case of severe allergic symptoms uncontrolled by simple measures. AIT involves the administration of regular, gradually increasing amounts of environmental allergen extracts by injection or by sublingual tablet sprays or drops under the tongue. And treatment is a long-term option, usually spanning for 3 to 5 years. Well, to further our understanding of these common conditions, I'd like to introduce Dr. Andrew Martin. Andrew is a practicing ENT surgeon in the southeastern suburbs of Melbourne and northern Tasmania. He completed his MBBS at the University of Queensland in 2008 after a Bachelor of Pharmacy Sciences with honours from Monash University in 2003. He completed his fellowship with the Royal College of Surgeons in otolaryngology and head and neck surgery in New Zealand in 2021 and completed an advanced fellowship in head and neck surgery at the Royal Melbourne Hospital in 2022. He has special interests in nasal obstruction, obstructive sleep apnea, ear and balance problems, chronic sinus disease and midfacial pain, paediatric ENT, as well as swallow, voice and throat disorders. He's a busy family man with 2 young daughters and enjoys hunting and fishing. It was a great privilege to have this conversation with him, exploring rhinitis and rhinosinusitis in more detail. Please welcome Andrew to the podcast. Andrew Martin, it's a great pleasure to welcome you to Everyday Medicine. Thank you for joining me after a very long session in theatre. I really appreciate you making the time, finding the energy, and joining us on this very intellectual podcast, Andrew.
Thank you for welcoming me, Luke. Looking forward to it.
We love ENT. There's a bit of a crossover with gastroenterology. And I often find with ENT type problems, and we're going to be discussing a few in a moment, that it's often not handled perhaps quite as adeptly in primary practice as it could do. I never really felt I got much exposure to it as a medical student and young trainee. So I really appreciate you bringing your knowledge and experience along today. We're going to be talking about several things. We'll be talking about allergic rhinitis and sinusitis. We'll come back for another episode on mid-facial pain. Then we'll come back for another episode. Thank you for bearing with me for all these, Andrew. It's fantastic to have you along on globus and chronic cough. Before we do so, Andrew, can you give me a little insight into your training? Why you chose ENT, how you got here, what your journey has been into this specialty? Take us through it.
Yeah, so like yourself, Luke, I didn't get much exposure to ENT at university, but I do recall 1 week just shadowing a registrar and just watching a grommet go in. Very simple procedure, but I was fascinated by the anatomy of the middle ear and the eardrum. Then after being given an opportunity to do a registrar job as a sort of a junior doctor, I really enjoyed it. There was the opportunity to look down holes that normal doctors don't get to look down, such as the nose and the ear, all the holes of the head. And also, I always found it interesting to know a lot about a fairly small area of anatomy, but where there's a huge amount of variety of what you end up looking at. You look at anything from a dizzy patient with chronic vertigo or someone with hearing difficulties right through to swallowing difficulties, facial pain, head and neck tumours, paediatric snoring. There's just so much in there that just makes the whole thing very interesting and stimulating. And we get to play with endoscopes, microscopes. We get old patients, young patients. So I've always found ENT very interesting. And we don't really have a medical equivalent specialty, but we do overlap with a lot of other specialties. We overlap with, obviously, yourselves, Luke, in the area of the upper GI tract. We overlap with neurosurgeons at the skull base. We overlap with general surgeons around the thyroid and the midline of the neck, and plastic surgeons when it comes to the skin. So really, it's a very interesting area, and we obviously share a lot in common with other doctors.
Like the lung physicians and so forth as well, allergists. Yeah, I think it's one of those areas too, Andrew, would you agree, where ENT type presentations are extremely common to primary practice and also to emergency departments. So when someone's got a foreign body in their nose, or they've got blocked ears, or they've got a bit of whatever it might be, vertigo and so forth, sore throat, these are very distressing symptoms for patients, and they often like them resolved very quickly. So it's great to have someone with your expertise out there. And this education.
I think it's often things that are not necessarily straightforward. You can't just look at an X-ray and always make a spot diagnosis. A lot of the time it's dependent on the history, like it is with a lot of more medical specialties such as yourself.
Well, let's start with a little discussion on allergic rhinitis and sinusitis. What are these conditions? Are they the same condition? Are they different conditions? Can you just tease them apart for us so we can understand what they are, and then we'll come to how they're diagnosed and what we should be doing about them.
Yeah, no, I think it's an area that deserves a clear explanation, because I think these things are often confused. Simply put, rhinitis means inflammation inside the nose. Sinusitis means inflammation in the sinuses. I like to talk about the nose and sinuses a bit like two townhouses separated by a middle partition, namely the septum. The turbinates are like the furniture inside the passageway, and the sinuses are like the rooms of the house. And if the disease is predominantly affecting the passageway, then that's rhinitis. If the disease is predominantly affecting the rooms of the house, that's sinusitis. Now, it gets confusing because nowadays we refer to sinusitis as actually chronic rhinosinusitis. So it's true that there's some inflammation in the nose, but the primary problem in sinusitis is a interaction between the epithelium and the environment, leading to inflammation of the sinuses, whereas the predominant problem in rhinitis is actually within the nose itself. So allergic rhinitis is the most common form of rhinitis, and that's just a type 1 hypersensitivity IgE-mediated reaction. In other words, it runs through histamine as its predominant autocoid. And so treatments are often geared around dealing either directly with histamine, such as, systemic antihistamines, or topically using steroids, which really mitigate the downward effects of histamine. So that's a very well understood condition. Sinusitis, that is inflammation of the paranasal sinuses, like I mentioned, the rooms of the house. Really, we're talking about something that's much less well understood, and it's a heterogeneous group of diseases. But for simplicity, there's two types. The first being that without polyps, and that the second being that with polyps. We know the type without polyps is neutrophilic dominated, tends to present with pus and edema, and the type with polyps is eosinophilic mediated, tends to present with polyps, and tends to be responsive to steroids, whereas the first type doesn't. Conversely, the first type, that is with the type without polyps, responds well to prolonged courses of macrolides, but the benefits of steroids in that category are less well understood. So how I define allergic rhinitis is a simple allergic reaction involving the mucosa of the nose, and it typically has very minimal involvement of the sinuses. And sinusitis is a condition defined as inflammation of the sinuses. It's diagnosed. The diagnosis is best summarised by the most recent guidelines in 2020, which basically said if it's less than 3 months, it's acute. If it's greater than 3, it's chronic. And you need both clinical symptoms, and then on top of that, you need either endoscopic findings or imaging. So symptoms are, there's 4 main symptoms we talk about. There's nasal obstruction, nasal discharge, rhinorrhea, either anterior or going down the back, so postnasal drip, that is, and hyposmia, that is reduced sense of smell. And you need 2 out of 4 of those symptoms and 1 out of 2 of either nasal obstruction or discharge, plus minus 1 or 2 out of facial pressure and pain or hyposmia. So you need 2 out of 4 symptoms. And then to support the diagnosis, you need either endoscopic findings, where you might see either polyps, middle meatal edema, or mucopus, or CT findings which confirm the diagnosis. So you need both, just to recap, history and examination. So that's how we diagnose
the sinusitis. So Andrew, is that sort of allergic side of sinusitis, which is associated with polyps, is that linked to the rhinitis that we've talked about? I know that all the itises sound the same here, but are they the same etiology or pathophysiology with those 2 conditions, or are they different?
So they're 2 different things. Allergic rhinitis is very clearly an IgE-mediated condition.
Right, so we set that aside.
And so, it'll respond to things such as antihistamines, omalizumab, which is a monoclonal antibody, which targets IgE.
Yes.
Whereas sinusitis caused by polyps, all we really know is it's an eosinophilic reaction, but it's not IgE mediated, even though IgE also causes eosinophils. So that's where the confusion lies, I think, and why people tend to sort of blur the lines a bit between those 2 things.
We're not quite sure what the etiology is in driving that eosinophilic sinus.
Yeah, so look, all we really know fundamentally is it's an interaction between the environment and the mucosa. We know people that will develop it late in life when they move to a different location. So we think that there's probably some environmental trigger, but it doesn't lead to that release of histamine that characterises something that characterises atopy. Whereas allergic rhinitis is just a form of atopy involving the upper aerodigestive tract or the nose, as opposed to, either the lower respiratory tract, or even in your case, I guess you might see eosinophilic esophagitis in some cases.
Yes, stimulated by a whole range of food proteins, cow's milk protein and soy and so forth in that instance. So it's fascinating you get the same sort of, immunological process occurring in the sinuses, but we're not really...
Yeah, if I can digress there, Luke, is eosinophilic esophagitis caused by atopy, or is it kind of a different category?
It's a slightly different category. It's an immunological reaction, though, to a food protein. And I find it fascinating. There's 6 that have been identified. Sphenoid cow's milk protein. Often people think, oh, no, it's the lactose. Nothing to do with the lactose. Cow's milk protein. Or it could be soy, it could be gluten, it could be the protein that's in seafood, it could be shellfish, it could be nuts, or it could be eggs. There are other things as well, but that's the main list that we sort of think about when we approach eosinophilic esophagitis. And it's fascinating too that it doesn't occur elsewhere in the GI tract brought on by those proteins. It's very esophageal specific. It's interesting. We now have dispersible budesonide as a very effective treatment to manage it, of course, along with avoidance of those food types, or we try and minimise exposure to those. Now, we've got physical things we can do. If the esophagus is a bit tight, we can stretch it up and so forth, although we have to be cautious with that, can tear. But that's what we have with eosinophilic esophagitis. But we've got this condition in the sinuses, of which is, again, as you say, not totally understood by the sounds of it. What about the non-polyp form of sinusitis? What drives that?
Yeah, so that's neutrophilic mediated, whereas just to clarify, the polyp form is eosinophilic driven. And so It's run by different, if we really want to get technical, it boils down to the helper T cell type that reacts to whatever it reacts to, and that we don't really know what that is. And the helper T cell driving it is a different helper T cell, so it's Th1 as opposed to Th2, which drives the eosinophils.
Yes.
And so that eosinophil recruitment leads to polyp formation, whereas neutrophilic recruitment simply leads to inflammation, pus, much like you would of any kind of abscess, I guess, in the body. It's kind of, if you think about it, the sinuses are a whole lot of air pockets in the face. And so if you get inflammation there, you can develop pus, and that's kind of the sort of inflammation that it is, which is probably why it responds so well to macrolide antibiotics. Antibiotics, I should say. But no one really knows why macrolides work so well. But we also know that people with neutrophilic-driven inflammation in the lower respiratory tract or the lungs also respond well to prolonged courses of macrolides.
Right.
So we think it's, there's this sort of concept now of the unified airway, that whatever drives inflammation in your lower respiratory tree, as in the lungs, will do the same thing in the nose.
So, Andrew, someone presents who's got sort of sinus type symptoms or maybe nasal symptoms, and you're suspicious of this diagnosis and you're in primary practice. What's the best test that, say, a general practitioner can call upon to try and help clarify this diagnosis and separate these three things?
I mean, I'd start with a good history. The history, you want to ask about the 4 cardinal symptoms of sinusitis. So nasal obstruction, nasal discharge, facial pressure or pain. Now, what they often describe is pain or pressure in the distribution of the sinuses. So either be it by frontal, over the nasal bridge, or by maxillary. Okay, and some of them even give a really classic symptom that when they bend over, they can feel pain or fullness or pressure. If you've ever experienced an acute episode of sinusitis, you might be able to relate. And then the 4th sign so just to recap, nasal obstruction, discharge, facial pressure, is inability to smell things. Now, typically, you really need the combined presentation to alert your suspicion, because people can present with any one of those symptoms in isolation, and it's likely to be something else. So nasal obstruction on its own is often just something simple, such as septal deviation, or allergic rhinitis, which we mentioned. But those people with allergic rhinitis will typically get the systemic symptoms of allergy, so the itchy eyes, the sneezing, and they may get classic seasonal symptoms, etc. So those people kind of often know their triggers, the people with allergic rhinitis. So it's interesting that they know their triggers, and so does science, whereas with the sinusitis, there's not really a known clear trigger. It's just that they present predominantly with nasal obstruction and discharge, plus minus facial pressure and pain, or hyposmia. So if, just following my train of thought, if people come in with a single symptom on its own, usually not sinus disease, an example would be facial pressure and pain. If people only come with facial pressure or pain, but no nasal obstruction or discharge, no hyposmia, you're probably talking about mid-facial pain syndrome, which we'll elaborate on shortly. If someone presents only with hyposmia or inability to smell things, it could be age-related, it could be simple allergic rhinitis, and so it can be, i.e. conductive hyposmia, that you're not getting the odorant molecules up to the olfactory fossa, or it could be post-viral. You think of COVID, notoriously, head trauma, other things like that. So you sort of want that combined presentation. Then you might talk about special investigations that'll help you in general practice, and the easiest thing to get, and it's very available, is a CT of the sinuses.
So that will help you distinguish also if there are polyps there or not polyps there. I'm sort of thinking, how does someone know if it's neutrophilic or eosinophilic?
Polyps, what I would recommend every GP does in their practice is just get the good old otoscope and put the largest fitting ear piece on the end and just look up the nose. Very often you'll be able to see pretty clearly. The first thing you look at are the turbinates, which some people confuse for polyps, is that they're symmetric. They're right at the junction of where the external nose meets the skull. and they look like a pink fleshy colour, whereas a polyp looks typically white, and it typically emerges between the turbinate. So if you imagine middle turbinate up here, inferior turbinate, the polyp will be coming in between the two, often draped over. Yeah. Polyp disease, I mean, I see it not uncommonly, but it's not super common. In general practice, I imagine you wouldn't see them very often because we get funneled all of these patients. But I imagine that you'll see a lot more allergic rhinitis and CRS without polyps than you will true polyp disease. Not that it's as rare as hen's teeth or anything like that.
So we've talked about, how you might treat rhinitis. We've talked about macrolides for the neutrophilic sinusitis. And just remind me how we're treating the eosinophilic sinusitis, which is associated with these whitish polyps that we're discussing.
So this is interesting, Luke, in that depending on the severity of the disease, some of these people actually need upfront surgery. So generally speaking, most of the time in ENT, and I'm sure it's the same in your specialty, you try conservative measures before you sort of escalate the throw the book at it and do an operation. And that's certainly the case for chronic sinus disease without polyps. We often try a prolonged course of macrolides. We try topical rinses and nasal steroids, usually twice daily for, let's say, 6 to 8 weeks at least. But if those measures fail, then we think, well, okay, we can always resort to surgery. We haven't smashed the glass ceiling until we've done an operation. And hopefully we don't smash the glass ceiling doing that. But with polyp disease, not that the treatment is unimodality, because they're still going to need topical sinus rinses with steroids added. They're still probably going to need courses of systemic steroids. And now we also have immunotherapy, which has been approved for recalcitrant disease. But just to stress, it's only been approved for patients who've had surgery, then get recurrent polyps, and are kind of at the point where they would need another operation should they not get the treatment. And so surgery is still, for people with polyps, provided that they're symptomatic, they need surgery. And if they came to me, and I not uncommonly see patients who have quite florid sinus disease. You look up their nose and there's polyps poking out through the middle meatus. There's even a bit of pus draining there. You're like, would you like an operation? And they're like, oh, no, that sounds terrible. I wouldn't want to have surgery. You're like, no problem. Call me again when you have any trouble. And you still try your best to optimize them, but you know that they're never going to become asymptomatic till you clear all of that out. No. So at the end of the day, I do believe that people self-select for major interventions, and it's based on how miserable they feel with their symptoms.
So, Andrew, once you've cleared the polyps out, you still have maybe the underlying pathophysiological process there. How do you prevent that from returning, or is it very difficult to do that?
Yeah, so that's the holy grail, ultimately, to find something that would just turn off that switch. Because the idea of surgery is not really to modify that process. And I'm not convinced, I mean, I've heard people make such claims, but I've never really been convinced that we do anything to switch off that immune switch by the operation. I like to say, going back to the house analogy, that we're creating an open room living in the nose. We're knocking down the internal walls. We're unifying the rooms with the common passageway. So we're allowing the sinuses to drain adequately, because they're all mucus-producing surfaces, and we're allowing the treatment to get in there, whereas before, because of the edema, all of those tiny little natural ostia were all closed off. And I think we do circumvent some of the secondary problems, such as inspissated mucus that can't drain, that then gets secondarily infected. And I think that probably does have a knock-on effect at reducing inflammation and further polyp formation. And it is interesting because it is effective, because we find that about 85% of all patients who have sinus surgery for polyps will never get any significant recurrence to the point where they need another operation. But there are some very significant subsets that have been proven historically to present with terrible disease, and the most notable one is aspirin-exacerbated respiratory disease, formerly known as Samter's triad. And the triad, if you like, is chronic sinusitis with polyps, asthma, and worsening of symptoms triggered by non-steroidal anti-inflammatory drugs. Now, it's not like they're drinking aspirin in the water. What it is they have if you go back to pharmacology, you've got arachidonic acid that can go down either the prostaglandin or the leukotriene pathway. And if you give someone a non-steroidal, you block cyclooxygenase, which shunts everything down the leukotriene pathway. And we know that the prostaglandin pathway is, you've got pro-inflammatory and anti-inflammatory components, but overall the net effect is anti-inflammatory. And the net effect of the leukotriene pathway is pro-inflammatory. And these people have a genetic predisposition to shunt down the leukotriene pathway. So when you block the prostaglandin pathway off, they really shunt down that pathway. And they classically will give you the history that if they took a drug like aspirin or Nurofen, they start wheezing.
Yeah.
And these people historically came in with absolutely terrible sinusitis. I had a lady come to see me in the clinic a few weeks back, and she'd had 6 previous sinus surgeries in the past. And when I looked up her nose, there were some huge polyps. They just kept growing back. And sure enough, she had the classic history of non-steroidal reaction. But thankfully for her, she'd been seen by an immunologist 6 months previously, started on mepolizumab, which is now available for refractory or really recalcitrant sinusitis with polyps. And she said her nose has dried up, but even though there's polyps there, she's no longer getting any discharge or facial pain. And she just came to me to get a repeat prescription for her mepolizumab, which was fine by me. I didn't want to operate on someone that had 6 previous surgeries. And so this is great because we've now got options for these people who were previously in this just miserable hamster wheel, having to come back for the 6th or 7th operation.
Yeah. The development of these treatments has been phenomenal. Are you seeing a lot more presentations now? So many patients are on dual platelet antagonists now that I just wonder. I think aspirin's being used extensively. I would argue way more now than it has been, certainly in the 90s. Do you think we're seeing a lot more sinus disease as a consequence of that? And as you say, the consequent shunting down the leukotriene pathway from that therapy?
Look, I think it's never been fully established whether exposure to aspirin itself brings it on or whether it's just it exacerbates people who already have it. Right. I certainly did see one patient who I think that was the case, in that they'd started aspirin and they developed just systemic inflammation of every space in their upper air digestive tract. They ended up with middle ear effusions, severe CRS after starting low-dose aspirin as a cardiac preventative. So I think it's certainly possible.
And something to do in primary practice.
And look, one of the treatments was actually giving people a mega high dose of aspirin, but you'd start in incremental small doses and then give them these monster doses of aspirin, like 600 milligram 3 times a day, to sort of have a reverse negative feedback effect. So aspirin desensitization. The problem with it was, of course, is that if you skip one dose, you'd have to go right back to the start. And it's incredibly morbid. I think people getting GI ulcers, kidney problems, that sort of thing. So I think the last time I spoke to people that are really at the forefront of this, they said basically they're no longer doing aspirin desensitization. It's sort of fallen out because of these immunotherapy agents.
And the consequences of aspirin therapy. Well, look, thank you for running through those 3 problems and just highlighting what we should be thinking about, how they present, and the sort of treatments that we should be considering in primary practice. I'd like to thank you all for joining me in this conversation with Andrew Martin. I hope you found it as interesting as I did in regard to this very substantial topic of sinusitis and rhinosinusitis. During the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. You can request a new topic to be reviewed and comment about the conversation you've listened to by emailing to manager@johealth.com.au.